Un, dos, un, dos. Un, dos, 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 dos.
Ethical and Scientific Committee at the UC and also she's a member of the assistant network and the assistance committee in our university. So she is a very special person in our faculty. Dear professors, colleagues, students, and friends, I would like to welcome everyone to this event, which is quite significant for us. We hope that this course will be a true reflex of our commitment to human dignity, integrity, responsibility, and solidarity. Our mission guides us towards providing comprehensive healthcare centered on the integrity of every person and family. We believe in the respect for diversity and valuing the unique dignity of each individual. Our actions have always searched for the comprehensive integrity of people, and we want to be an example of today. By sharing experiences, we must remember that every moment it is an opportunity to check our previous knowledge, to learn, to grow, and to serve our community with humility. We hope that this course will be a testimony of our commitment to people's health, people with diverse genders, and we also want to contribute to a professional development of medicine. The secret of change is to focus our energy not to fight old concepts, but building new ones. We are very thankful to have earned your trust. We at the faculty at the School of Medicine at the Catholic University. I'd like to thank Eliana that will gives us a welcome message now.
Le doy el mérito.
I merit gender dysphoria as the worst feeling I've ever experienced. Many times when people speak of trans people and their process of change, people often think that the reason that motivates us have only aesthetic purposes, and they ignore the physiological terror that denounces that something's wrong, the terror of facing the fact that you were born in a body that is not yours, a body that you feel as strange and that makes you insecure. It's a body that, regardless if you have a penis or a vulva, will define your role in society, the way they look at you, the toys you play, the clothes you wear, the cartoons you'll watch, the way you should behave, and so forth. This presentation letter is what defines your role in the world. Most people, almost everyone, are fine with that. But what about those that are not? I was born as a boy, the second boy in a family. Even though my parents wanted a girl, since a very early age, I noticed that I was different from my parents. Even though I liked the Transformers movie, I had a secret relationship with Monster High and Tinkerbell, because even though I was impressed by that, the other children my age only liked football and Ben 10. Even though I was so small that I couldn't even wash my hands without somewhere to step on, I already understood something about the gender, and the way I acted was not was not acting accordingly to the behavior of a boy. After some time, my mates would grow mustaches and their voices would grow deeper. So I saw that how gender dysphoria was coming towards me, and I was terrified. Puberty was an agonizing moment. After taking the best decision, I believe, in my life, I exposed the situation to my parents, and I received all the support in the world. They also had questions and doubts and fear, but that was key to build the basis of my identity that would allow me to live a fulfilling life and an honest life, especially to myself. I would like to thank my family to have accepted me for being and not for the expectations I did or did not fulfill. As a trans person, the most essential thing we need to transit is a support network of people who you can trust. Thanks to that, I was able to start since a very early age, socially and medically. I saw Dr. Alejandro Martinez, who gave me all the medical need I needed to align my outside with my inside. I began with hormone blockers at 13 and estrogen therapy at 14. I did not develop my secondary sexual characteristics. I did not grow a beard. My voice didn't change. My Adam's poem did not grow. So this made me so happy with myself that I can truly tell you I wouldn't change that for anything in the world. Even though I am a role model, since I have lived my life like any other teenage girl, a 17-year-old teenage girl, trans people often do not have the same luck. Many families turn their back on them and they did not get medical support, having problems later on in their adult life. Thanks to the decision of my parents, my doctor, and myself made, I can be here telling my story and making you aware of that so that my case, my exemplary case, can become the rule.
It was brought to my attention that there are some people here today who speak English. So I proceed to give a summary of everything I just said whilst also putting my English to use because I want to study abroad, and so why not practice? I was assigned male at birth, making me the second male child in my family. Since a very young age, I've been aware of the social structures you're put in because of your gender. Although I loved the Transformers movies, no pun intended, I had a secret obsession with Monster High and Tinkerbell. When I reached the age of 12, I started to notice how my peers were developing. Some of them had their mustache come in, their voice dropped, or they grew an Adam's apple. That was the exact moment the dooming feeling of gender dysphoria set. The wishing upon, the closest thing I can describe it as is, imagine there's this process everyone your age but you are wishing upon going through. Everyone sees it as a pivotal moment, the transition between being a kid and turning into an adult. For you though, it's the whole opposite, because coming to terms with how your body will develop from now onward is excruciating. I didn't want to grow a beard, nor see how my voice dropped, or anything of the sort. After what I can confidently say was the best decision of my life, I came forward about the way it felt to my parents. Being greeted with unconditional acceptance, giving me a very much needed support system to fall back on. This doesn't mean they didn't have questions, although it did mean for me that I was now able to create the foundations for my identity, and therefore the foundations of my life. Shortly after coming out, I started my medical transition with Dr. Alejandro Martinez, who I give credit for giving me the medical treatments I needed to align my inner self with my outer self. By 13, I started puberty blockers, and by 14, I started with hormone replacement therapy, thus keeping me from going through irreversible changes. I'm aware of how I'm a rare success case when it comes to the norm with trans people. I'm also aware of how many, perhaps too many, trans young women and men don't get a fair shot, whether it's because their families don't support them or because they're denied the medical care they need. Because of the decisions my parents, my doctor, and I made, I can stand here today and spread awareness so that one day my success story can become the norm for all trans people, so we can all live a life we deserve. Muchas gracias por su atención.
Buenos días, estimados participantes. Es un honor.
Good morning, dear participants. I'm happy to welcome you to the third symposium of comprehensive care to transgender people, a unique opportunity to deepen our knowledge and our comprehension regarding the diverse realities of transgender and diverse gender people. We want to foster a space of learning, dialogue, collaboration among professionals dedicated to this important area of healthcare. Our symposium has 4 modules, from neurodivergence to diverse genders and surgical aspects, and others. Experts from many areas will share their knowledge through speeches and roundtables, providing tools and knowledge to improve healthcare for trans people, facilitating therefore a comprehensive learning for healthcare professionals. We hope that this course will be useful for you in your work with diverse gender people, providing you tools, knowledge, and a professional support network. We'd like to thank you for your participation, and we believe that this will be a very enriching opportunity for everyone. Finally, I want to thank the Pfizer and Sandoz labs that are truly supporting diversity and inclusion and that have allowed this course to take place, and therefore providing more affordable prices for this course. With that, let's move on to our first module.
Santiago, es magíster en salud.
Master degree in public health in British Columbia. Since 2015, he's worked with civil and community organizations and with specialized clinical teams specialized in LGBTQIA plus populations well-being. For example, his role in the Todo Mejora Foundation and also the support group at the UC Christus Network work. That's where I forged my friendship with him. In 2018, he was clinically trained in the Gender and Family Project in the Ackerman Family Therapy Institute in the United States, and Dr. Sierra is currently a student in the Public and Community Health in the University of British Columbia, and he's a researcher in the Digital and Sexual Initiative Group in Vancouver. So it is a pleasure to hand the floor to Dr. Sierra.
Trans y no binarias, las discusiones que hay sobre las expectativas.
The discussions regarding clinical expectations differently from the attention deficit in children. Hello, good morning. I'd like to welcome to this first presentation. I'm Rodrigo Sierra. I'm a children's psychiatrist and a master in population and public health. I use neutral pronouns and male pronouns. Today I'll talk about the intersection between neurodivergence, non-conforming gender, and trans identity based on scientific literature. In this presentation, I will refer to the more general intersections between gender and neurodivergence. Also, we'll go over some definitions and language aspects that are critical to have a common language in this discussion. I will also refer to some common aspects in the treatment received by the trans and non-binary population and neurodivergent people, and also a brief analysis of the empirical evidence that is currently used for these intersections, and also to provide some guidelines, practical guidelines for the work with people in the autistic spectrum and in relation to gender as well. Gender and neurodivergence have been historically linked since the beginning of the neurodivergence studies. An example of this cross-relationship is the theory of hypermasculinization as a alternative theory for autism, and also the discussions regarding clinical expectations, which are different from the attention deficit is presented in children. These controversies are quite relevant still nowadays, and one of them is the interpretation of the diagnostic criteria in terms of gender and how this impacts the rates of diagnosis and identification of neurodivergence in women and girls. I'm not talking about trans or non-binary people yet. When we talk about this cross-relationship, there is a growing clinical and scientific interest. To the right hand, you can see a graph of a systematic review, quite recent one, in which we observe a sustained growth in the number of scientific reports showing the intersection between autism and non-conforming gender. What we know about attention deficit nowadays is closely related to that, and most of this presentation is the graph that you can see at the lower right part of the screen, shows the adolescent rates. These studies show numerous tensions and controversies. This is part of what we're going to see today. Now, the first part is about definitions, to have some definitions, so I'll give you some language notes. You might have already noticed some of these terms I use. Therefore, when we talk about neurodivergence and neurodiversity, they can be understood as a paradigm. It's like a lens through which we see reality and we define concepts. This has implications in social phenomena, clinical practice, and it is important to understand what we're talking about. What this paradigm establishes is that human population has infinite diversity in terms of phenotypical expressions, and these expressions tend to group. There are people who look like each other, and there is a great mass of people that has a certain profile, which is here at the center. That does not exclude the possibility of having other groupings or phenotypical groupings of people who look like each other and do not look like this central or majoritarian mass, which is I am expressing here or illustrating as these circles on the outskirts. So at the center would be what is called typical. It is only based on a criteria of frequency. And this typicity or higher frequency has no defined criteria for what it is. This is called neurotypical. Versus the other ones, for which the trend is to establish diagnostic criteria to define what enters and doesn't these categories, which are the diagnostic criteria of in what we use in psychiatry, for instance. This was born from the activism of autistic people in their work regarding neurodivergency or disability. So most of the theory has always mentioned autistic people. However, this has been growing and including everything that is called behavioral deficits, such as attention deficit disorder, d- dyslexic people, language specific disturbances. So people also go beyond that and include psychiatric diagnosis such as bipolar or compulsive obsessive disorder. And some people go beyond that and talk about diagnoses that are not behavior linked, those things that are genetically programmed and environment related. For example, post-traumatic stress disorder and other expressions that are chronic in some people, that remain with people, and that have a neurobiological base. Since these terms come from academia, well, this cannot be defined or considered definite unless the academia starts including them and working on them. So the first thing is to trying to refrain from using disorder. This can be variations of behavior or the brain structure of people who show different phenotypic manifestations. What is neurodivergence? Any type of behavior that leaves this central majority mass of typicity, and there is no specific form of neurodivergence. There are many forms, and the complete universe, when we talk about this, would be called the neurodiversity universe, including all people, neurotypical and neurodivergent. And this has some implications in how we use language. In this course, I shouldn't define what the identity of trans and non-binary people are, but they are terms who contain a multiplicity of possibilities. These are very dynamic terms and that are anchored in our social dynamics, and that we must start to think of how many of them are under the trans umbrella or non-binary umbrella, how they are divided. So there is a lot of enriching concepts here that will define how we use these terms as humans. Now, scientific literature is strongly biased to compare gender diverse behavior with trans identity. So the criteria, they are basically the same. Therefore, they still replicate some concepts that are quite problematic in how we shape these identities and at the level of how this population is defined when in the healthcare systems. So the 11th version of the CIE, there is a rupture with this diagnostic movement that show no criteria and only a general description, and this is under a chapter that does not address mental diseases as an effort to move out of the paradigm of the psychiatric conditions. Therefore, we can discuss how much of that is actually translated into clinical practice. There are many specialized teams that are working on that. Now, to address this from a diagnostic point of view, this is quite problematic. There are cisgender people who can also have some gender dysphoria behaviors, which have been historically defined as trans. So changing their names or other types of movements have been trying to establish this difference, but they are not reflected in scientific literature, particularly the DCM or gender dysphoria talk about toys that are expected to be used by certain genders, and also they assume some behaviors in their conceptions. By doing that, they pathologize certain identities and others not, basically defining this as a social phenomenon that contradicts all principles in which the manual is built upon, and also with the changes of time criteria, which has been the only significant change between versions 4 and 5. When we use the list of criteria as a diagnostic measure, they expand the sensitivity to identify people who will go through gender transit, providing healthcare, if we consider this as a diagnosis. There are new approaches in the scientific literature and medical literature. There is a predominance of the non-conforming genders that has a focused on not feeling comfortable and to challenge social norms, and the best articles nowadays in the medical area tend to talk about non-conforming gender and try not to establish gender dysphoria diagnostics. Understanding non-conforming gender with different types of evolution that does not relate directly with being trans. I cannot go into details right now, but non-conforming genders is the best language available nowadays in medical literature. Other specifications, well, the disability theory is a topic in and of itself. This also has to do with language, with the identity first theory, where people describe themselves as this being something that cannot be separated from themselves, like we say the autistic person, versus the people first language, which is the difference between the people and the disability, which is a person with autism. Now, the overgeneralizing, maybe I'm overgeneralizing, but adult people tend to prefer the identity first language and for neurodivergence specifically, but it's not the case for everyone, and it's always preferable to ask people what language makes them more comfortable. In this presentation, I will be using basically the identity first language as a way to describe this in a way that is more inclusive. The other thing is diversity versus divergence. Neurodiversity includes the entire universe. Human groups, whatever they are, can be neurodiverse because they include many people and many phenotypical expressions. But individuals cannot be diverse because they are one point within the universe. Therefore, a person can be neurodivergent but not neurodiverse. Some people are also talking about neurodissidence, that has to do with relationships as well and the political aspects as well. We can talk about similar things when it comes to gender too. And finally, let's be careful with the covert pathologization. And in the articles, you will see the synonym between gender dysphoria DSM-5 with trans identity, which is not always the case. So with these caveats, understanding scientific literature must be a very careful process and a critical and analytical process as well. There are some intersections that are more specific. Some of them are multiple, both blocks, the trans and non-binary population, the neurodivergent population, they have these intersections when they are faced with the medical models. The pathologization, dealing with them like they are sick people. Also, inadequate use of language that is quite frequent even for people who are in a more inclusive mindset or with the best intentions. They can sometimes use language inadequately, and this generates problems. Another very important element is conditioning healthcare, being subject to professional evaluations. For example, psychological reports for hormone treatment or for some educational program inclusion. This has to do with the external control of identification, telling people that they don't know who they are, they cannot define who they are, and I, as a professional from the outside, can tell you who you are. And finally, there is an overlap between corrective interventions, trying to correct this as being a problem. In this case, the ABA model that is deeply questioned by the autistic community has been used to correct behavior linked to gender expressions.
There are other intersections that are quite hopeful, that these adjectives are more specific. For example, the idea of neuroqueer in the Anglo-Saxon literature tells us about a broad intersection between LGBTQIA+ neurodivergence and autigender. It is linked to the autistic experience of the person that goes hand in hand with other labels to describe the gender identity of the person. Now, what does empirical evidence tell us about these intersections? The first thing is to tell you that the clinical epidemiological research has been focused on the questioning of gender identity and autism and non-cisgender identities. Research and the forms of neurodivergence is quite emerging, it's quite early. There is another review, which is the one I showed at the beginning of my presentation, which included some studies on what is known as attention deficit disorder, which includes just 4 articles, not more than that. They say there is a higher probability, but there is nothing else about hypotheses or more specific clinical descriptions. So to just say there is a higher probability of being neurodivergent and what is known as a non-binary, and there is nothing else they say. So the rest of my presentation will be focused on autism and non-conforming gender. This statistical association is bidirectional. Autistic people have a high probability of not being heterosexual and high probability of having inconformity with their gender. And on the other hand, in the specialized clinics on gender, it's being reported a higher probability that they are autistic as well, or that autism is identified as part of the accompanying of those people in such clinics. This has been demonstrated in different research. All of the reports mention an association that exists. Maybe there is a publication bias. We have to be aware of that. However, all of the research is aiming at high probability of up to 50% of visits to gender clinics that present clinical characteristics that make evident the need of considering autism as part of the process. The specific relationship in numbers varies according to the population studied and the methodology used. As I said, in some cases, it is up to twice as much the prevalence of non-conforming gender in the autistic population as compared to the population at large, and up to 6 times the possibility of identifying autism in trans people versus population at large. But all of this varies based on the methodology used. And we have to consider that we have to be quite cautious in how you read those studies, because some of them do not have a control group. Some of them use screening to define the phenomenon, but not formal exams. And applying diagnostic approaches that could be questionable. And some selection bias risks that I'm going to describe next. In the general population, there is this epidemiological twist. In the first reports, there was a clear predominance of people assigned as male when being born now. there is a reduction of that proportion or a change towards a female assignment at birth. And this has sparked a lot of debate in the medical and scientific community. However, in autistic populations so far, the evidence aims at the ratio is 50-50 regarding sex assigned at birth. But some say that there is a majority of one or the other. So probably the evidence is not conclusive or is quite local. Clinics have tried to describe a profile on characteristics of autistic people that go there. There is this profile of people with a late identification of autism, quote-unquote, diagnosis or identification when they're older. And this is people that have a fluid verbal language and masking skills that allow them to function and be unnoticed, the neurodivergence of them to be unnoticed. But there is a high risk of selection risk because nonverbal people with more difficulties in general are systematically excluded. Someone that is nonverbal won't be taken to a gender clinic based on the criteria. So it's not that those people do not exist, but maybe they are not arriving at the clinics. And that's why they are doing this profile. Now, recognizing this co-occurrence raises special challenges for the whole process on how gender identity is developed in people and also how care is provided. However, there are some consensus, temporary consensus, such as excluding some visions that have been considered as reductionistic, such as saying that there are autistic people that have, quote-unquote, some restricted interest to certain things, and that makes them look as if they were non-conforming, and denying the occurrence, for example, social difficulties of trans and non-binary people in their development predisposes them to have social communication problems, but it's not autism that denies all of the other characteristics of autism that could be present and that are observed. I tell you this because if you do your job of making this review of the literature on your own, you will find contradictory publications, mutually exclusive hypotheses, things that are deeply questionable. And then we have the explanatory hypotheses, causal hypotheses, and non-causal hypotheses. With the alert sign, these are a bit problematic. Usually, biologically based ones, hypermasculinization of the brain, the idea that there are chemicals that alter the endocrine function and alter the gene expression. So they're trying to say that there are chemical substances that are identified that could be removed, and thus avoiding having autistic people and thus avoiding having non-conforming binary trans people. And as I said, this hypothesis of the error in the diagnostic formulation has been questioned. There are other cognitive hypotheses on how cognitive rigidity, autistic people see binary as rigid, and nobody meet 100%. The stereotypes would be kind of out of place, out of the binary. We could question there what could be embedded in those explanations, but this is not ruled out as a hypothesis. And then the idea of the potential bidirectional influence, where autistic and trans and non-binary people would have an experience of autism and non-binarism that cannot be separated. So they have an experience that makes them different from neurotypical and trans people and cisgender people, neurodivergent and trans. I would like to give you some practical elements, some essential points. This report promote an active question of this relationship in the clinical practice, targeted assessment of clinical autism elements in patients that consult due to gender, and also propose conversations around gender in autistic people. The idea is to have professional teams with experience in both areas. Needs of these people should be catered at that level, but when that's not possible, we should work together, both teams, in the best way. The other important point is that under no circumstance, by being autistic, there is the exclusion of that person to being trans or non-binary, and the latter by itself is not a limitation to the capacity of consenting and medical intervention. Other elements validating the experience of the person who asks, avoid underestimating, also see what is the support of the environment of the person, which is quite important as far as the health outcome of these people. Psychoeducating on definitions, concepts that are necessary to do this job, speaking about identity, gender expression, non-conforming gender, why this is not synonymous with trans identity, etc. Building a space for exploration. We should produce a personal narrative around gender, and this should allow to construct identity. And for many people, this will be useful to promote concrete explorations such as a way of clothing, pronouns, roles, and explore alternative forms of generating narratives. Many autistic people will not be more comfortable verbally. They will need to draw, maybe draw comics. I mean, you should have to open to other possibilities beyond the verbal therapy. We have to adjust the accompanying to the profile of the personal characteristics. Some people have sensory profiles, others will have a more marked dichotomic thought that will have to be tackled at a certain point. This could be linked to non-real expectations, thinking that the hormone treatment can be changed or not. This requires a lot of work in adjusting the process of consent. The social dimension is so important. Support groups are not necessarily safe for autistic people, and autistic groups are not necessarily trans-inclusive, and not everyone will think that that is the best way to receive care. And finally, setting clear limits in the resolution capacity. There are cases that are really complex. The referral networks have to be well known. Conclusion. Neurodivergence, trans non-binary identities, and questioning of gender identity are usually linked. It's possible that the trend is a higher report of co-occurrence. Neurodivergent and trans people, non-binary people, and those that question their gender identity have a common relationship that is quite complex with the biomedical health model. Almost all of the research and intersection of neurodivergence and trans identity, non-binary and gender non-conforming has centered on autism. There is very early research in other areas of attention deficit. Current evidence aims at a high proportion of autistic people with non-conforming gender and vice versa. So we require to do more research in this regard. Every autistic person that requires professional support or transition and questioning to gender will have a particular profile of the need of adjustments, and those companies have to be adjusted to that need so as to be able to help this person in the planning of their questioning and constructing their identity. Thank you very much for paying attention to my presentation, and I'll be ready to participate in the Q&A.
Quisiera
I would like to remind the audience
las dos presentaciones que vienen a
the two next presentations are in English. So please, if you need a translation device, turn it on, and because there will be simultaneous interpretation. I want to remind you that the time for questions will be after the third presentation, so that you can write down your questions. Dr. Sierra Malpas and Dr. Mesker. Our next presentation is by Jan Malpas. Jan Malpas is an advisor to mental health and family therapist and couple therapist. He's certified. He's a specialist in mental health, LGBTQ+ since the year 2000. He was trained as clinical psychologist and psychotherapist at the Vrije University in Brussels, Belgium. Then he was certified in couple therapy and family from the Ackerman Institute for Family, where he would become director of international training, was a faculty for more than 15 years. In 2010, he founded the Innovating Gender and Family Project at the Ackerman Institute, a leader program that since then has supported more than 700 families with transgender people. Since being 3 years old, he's the founder of the Center of Psychotherapy Jan Malpas in New York. And he's partners of Parallaxe, a center for training based in Paris. We're going to leave you with Jan Malpas.
Hello, my name is Jean Malpas, and my pronouns are he, him, his. I was trained in clinical psychology in Belgium, and I practice as a couple and family therapist, specializing on gender and sexuality here in New York City. I'm delighted to be included in the conference. I'm going to share my screen so that you can see the slides as I speak and walk you through them. I'm more than happy to send these slides your way, so you don't have to write down everything. I'm going to focus on how to provide affirmative care for gender diverse children, adolescents, and their caregivers, their family members. It's an enormous topic, so I will really do an overview and a summary of some of the important elements, trying to keep it relevant for you and your medical practice, but it's obviously something that should be talked about for much longer. I'll skip over my background, but I've worked with trans, gender diverse, non-conforming children, adolescents, and their families for more than 20 years. I apologize for the background noise here in Brooklyn, New York City. Our goal was really to look at how to support and manage gender-affirming medical consultation, as I said. So we'll go over a few sections here. What do we know about gender-diverse children and transgender teens? What is the experience of caregivers and family members? What does the research say about best psychosocial practices with youth and caregivers, and what might be some implications for a medical affirming practice, and some questions that might come up for you. So gender diverse children are children who identify or express a gender that is different from their assigned sex at birth. For those who are prepubertal, that identification might be persistent, consistent, and insistent, and they might meet criteria for gender dysphoria in childhood, not pathologizing the gender identity, but really trying to capture the sense of discomfort and persistent and consistent discomfort that the child has with their assigned sex at birth. The age of onset of gender diverse behaviors, expression, identity varies greatly. Some kids are able to articulate that discomfort and that sense of identity really young, at the beginning of verbal capacities. And for some others, it comes around the beginning of schooling, or around in the peripubertal time, or even sometimes after adolescence. Before puberty, affirmative interventions focus on affirming the child, supporting their sense of self, encouraging exploration of gender identity and gender roles, if it's relevant and possible in the social context, facilitating or having a team that facilitates a social transition. There is no medical intervention before puberty, but it is established that having a good relationship with a pediatrician and a medical team for and if medical interventions are needed around puberty is a factor of well-being for the family and the child. There's been a lot of conversation about whether we can predict transgender identity based on gender diverse identification before puberty. It is important to say that some kids express gender diverse identifications and behaviors prior to puberty as a form of normal diversity in gender expression, and some kids express trans identities before puberty and will be persistent and consistent after puberty and continue to identify as transgender. We'll look at the numbers that we have from literature on that. But one thing is important is affirming the children having medical, educational, and family support. For children who are transgender or gender diverse identified really can help decrease the sense of depression or anxiety in the research population. We also see that the cognitive gender identity development of transgender children is really comparable to the one of cisgender children. So this is a great research project led by Christina Olsen and her team here in the US. She's gathered a fairly large group of affirmed and socially transitioned trans-identified kids between the age of 3 and 12, and following them over time. And I'm going to give you a few kind of research touch points on this cohort. And this grid here is to say that basically when you follow transgender identified children between the age of 3 and 12, their cognitive development around gender concepts, stability, constancy is pretty much the same. They are able to identify their gender as young as the age of 3. They show a gender expression that is usually aligned with their gender identity. They understand gender stereotypes. They have gender constancy. They understand that they were born in an assigned sex that is different than their gender identity, and also that they will most likely continue to identify in the gender that they identify now, even though they know that gender can be fluid and can change over the course of a lifetime. So there are different conceptions of gender, but cognitively it's just as clear as their cisgender peers. The age of realization of gender variance, as I said, varies. This was a lit review done about 10 years ago, 15 years ago now, but showing an important point, which is that a lot of kids realize that their gender identity is different from their sex assigned at birth around the age of 5 and 6. So before school, primary school, and also very important for pediatric practice. This is a more recent overview of trans-identified and non-binary identified youth in Canada, showing 2 points of onset of gender diverse identification around, again, the age of 5, 6, 4, 5, 6, around the beginning of primary school, or in the pubertal and pubertal time between the age of 9 and 13. So also very relevant for pediatric and adolescent consultation. The question of will trans children identify as transgender adolescents has been a big debate in our field. We've had very different longitudinal studies and numbers on that question, but I'll skip over to the latest outcomes that we have from the longitudinal 5-year follow-up study from Christina Olsen, who has looked at the kids that we were just talking about, affirmed at a very young age in their family and social context, about 317 of them, and looked at 5 years into the study. How are they identifying? Are they still identifying as transgender in a binary, non-binary way? Very important number here is that we see that a total of 97.5% of those children who identified as transgender at the beginning of the study 5 years later, so probably around pubertal years, continue to identify as transgender. Among those 97.5%, 3.5% went from identifying as transgender in a binary way, he or she, to transgender in a non-binary way, so might be using non-binary pronouns like they. 2.5% of the sample retransitioned to a cisgender identity. So important first, it's not detransition. They didn't go back in time. They understood something, and that allowed them to 5 years later say, I'm actually cisgender identified. Important to know also these 2.5% were the kids who had come out as transgender the youngest, and before the age of 6 years old, and their retransitioning as cisgender identified happened before the age of 10. So the lesson here is if a kid socially transitions before the age of 6, before school age, keep an eye on, I would say, like an open door and knowing that some changes might happen before puberty. Adolescents trans adolescents identify with a gender that is also different from the assigned sex at birth. For those that you will see, most probably are those who have been persistent, consistent, and insistent in a binary and non-binary way for several years. Again, a number of psychosocial interventions are in effect here, and with support of the individual, of the family, establishing a good relationship with a primary care physician, and maybe having some possibility to consult around fertility, preservation, and family building, and really getting an understanding of what are the medical affirmative interventions that might become possible and available after later on in adolescence. So education and education orientation on medical interventions become really important. One important piece here is that in terms of mental health, a lot of transgender identified youth show higher rates of psychosocial and mental health issues compared to their cisgender peers. Again, this is not pathologizing transgender teens. It is to say that this is the unfortunate effect of transphobia and cisnormativity, and living and growing up in a world that is not always kind and prepared to support these young people. But what we also know is, as I showed you earlier, is that once affirmed and once supported by family and in their social environment, the same transgender children and adolescents tend to do a lot better. So when we look at children who are in supportive environment compared to children who are not, what we see is that for the children who are in supportive environments, the rates of depression and anxiety are more or less comparable to those in the general population. So again, a big argument here for really working with caregivers, with family members, and supporting them. That evidence has been established for a long time. We know that family rejection is a high risk factor for a lot of psychosocial issues, including suicide attempts. This is a research here showing that LGBTQ youth and young adults who come from highly rejecting families have 8.3 times increased rate in suicide attempts compared to those coming from more accepting or less rejecting families. So again, family acceptance is protection. So it's important for you to work not only with a young person, but really engaging the family around providing education and information and support for the hardship that parents have. The family acceptance as a protective factor has been replicated on very large national samples in several countries, including the US. And what you see here is that, again, family acceptance is correlated with a great decrease in psychosocial risks, such as homelessness, suicide attempt, or psychological distress. Caregivers often experience anxiety, not knowing how to best support their young person, ambivalence, having conflicts about values or perspectives on gender identity, on parenting, on the best ways to handle the situation. They often experience grief, a form of loss, not of the child themselves, but of the story, of the representation, of the idea of the child that they were going to have. So some sense of loss, of sadness, helplessness and fear, which triggers great protectiveness and sometimes rigidity in decision-making. Some parents experience a loss in cisgender privilege, sort of, or a fear of being associated with the LGBT community and being ostracized and oppressed by their own community. We also see sometimes some familial and cultural conflicts within the family or within the parenting unit. But not every experience is negative. A lot of parents have also positive pride and joy, having a child who is able to articulate their sense of identity and ask for what they need. What we also know is that often parents are kind of stuck between, should I be more conservative and maybe a bit rejecting, but in some ways more protective, or more accepting? And they often perceive acceptance as a source of risk. And what we actually see from research is that acceptance is protection, that a child who is accepted and affirmed will grow stronger, will make better decisions, will be better protected in a social environment. So this is really something to educate the parents about, really understanding the real risks in their social context, in their neighborhood, in the school, in the larger family, but also really looking at how acceptance at home might have a psychological impact and a social impact that will be highly protective of the child. So what do we know about best practices with families? This is a systematic review of the literature that I did with a research team just a year ago. We looked at every English-speaking publication published on family-based interventions with trans youth and their families. Nothing in Spanish, unfortunately. We didn't look at the Spanish-speaking literature, just English one. Sadly, we didn't see any outcome studies for family therapy, but a lot of very consistent and common clinical recommendations for family practitioners in family medicine and primary care, therapists, psychosocial support, social workers. And these are the 7 ones. Again, they will be in your notes, and we can discuss them in the Q&A. But one is to provide education about the protective factor of family acceptance, provide caregivers their own space. What we see is that it's often very important for parents to have access to doctors and therapists and social workers who can hear their process, their fears, their grief, their doubts, and not rush them. And what we see is actually it's sort of a indirect correlation, or sort of reverse correlation, with really letting the parents talk about their concerns and fears and getting some clarity with a therapist or a doctor, and the acceptance that and the likelihood of them to be accepting and supportive of their children. And I misspoke, not a reverse correlation, a direct correlation here. We also know that families need to be helped in diverse modalities, so groups, family therapy, individual therapy, child assessment, social gatherings. All of those modalities shown to be most effective when kind of used all together. Facilitate access to community support, really important. So if you don't have a therapist to send to, have the name of one organization that the family can reach out to for training, for advocacy, for information. If you can connect them to a support group, those are showing to be some of the most helpful normalizing interventions. And of course, understanding the culture, the religion, the class, the type of access, the type of parenting and community culture that the family shares is the most important. There's not one model that fits every family, but obviously the cultural makeup of the family is the starting point of how to best support them. This is the multidimensional family approach. that I had the chance to develop over the past 15 years that really shows that to center and support transgender youth, we need to really think about all the relationships and all of the different communities around them, family, siblings, extended family, larger community, institutions, schools, hospitals, medical providers, and that best care practice really takes into account this sort of multi-systemic intervention. I was asked a few years ago to pick 3 main factors that help parents go from rejection to acceptance, which obviously is very difficult. And we looked at all the families who have been working with us at the Gender and Family Project that I was directing at the time. And what we saw is that increased awareness in understanding gender diversity was a great factor. Reconnecting with the child in some ways, having an emotional ability to re-understand the child in a different way and reintegrate emotionally and psychologically the new identity of the child was a great factor towards acceptance. And the third piece, which is really important when you come into the picture, is community. So no parent raises any child in a vacuum. It takes a village. So having a supportive school, having a couple of organizations that work with the family, having a supportive medical provider is key to family acceptance. So what are the implications for affirmative medical practices? And I want to say thank you to the different medical providers in the US and in South America and the parent advocates who have helped me highlight some important pieces here. First, know that gender diversity in childhood and adolescence is a normal human manifestation of gender diversity, and access to care is often life-saving. Know that the youth that you see might be socially affirmed and socially transitioned or not. Know that whether the child is gender expansive and will not continue to identify as transgender, or whether the child is persistent, consistent, insistent, and will continue to identify as transgender as an adolescent and as an adult, information and affirmative care will always help them. Remember also that no medical intervention happens before puberty, that the first medical intervention really is the blockers that happens at time of stage 2. And sometimes families need to be reminded that because there's a lot of misinformation about medical care being imposed on children before puberty, which is obviously completely not true. But know that the families and youth that come to your practice are most likely those who have experienced high level of gender dysphoria, that the family has been mobilized enough to make an appointment with you. And therefore, know that it is often when the family comes in front of you, and an adolescent or a preteen comes in front of you, you're often one of the first representative of the big social world that will be having a conversation with them, and that it is about being empathic and reassuring them and informing them about the different options that they will have, and building a relationship with the child and with the family. Children and adolescents are anxious, they have a lot of questions. Remember to take them, and also remember to emphasize that the support, the curiosity, the care, the acceptance that the family is showing is a great protective factor for their child. Families feel reassured by information, so giving them some guidelines on affirmative medical care is really helpful. I'm sure you'll go over this over the course of the day, but letting them know about puberty suppression, letting them know about the side effects that we know about that, letting them know about family building and fertility preservation, letting them know about cross-sex hormones in adolescence is also helpful. The pros and cons of each of those and the ways it's the follow-through and the follow-up that the medical team does with transgender teens. And then also the age of access to surgeries, top surgeries, or genital affirming surgeries are very helpful. As I said, you're one of the first provider to meet this family. Remember to model affirmative care if you can. Say your name and pronouns, show that you take these things seriously. Gather information about the family, the composition, and decision-making authority is really important. Who will make the decisions for the teen? Who will make the decision for the child? Who has what opinion on the issues? Who is in conflict? Is there someone out of the room who's going to make decisions who you should know about? And then if you can, try to have every person who's a decision maker in the room. Sometimes I find it really important to have meetings only with the parents, or only with one parent at a time if the parents disagree. Sometimes you unfortunately cannot do that time-wise, but if you have a family meeting, these are a couple of guidelines for how to navigate it. And very often the child is anxious about puberty, and it's important to acknowledge their dysphoria, and but that you also want to make sure that they get to ask the questions that they have, and that you check with them to see if they've understood the information you're giving them. Emphasize with parents that they're the most protective factor, that they're the decision makers, that you will be really discussing with them the pros and cons and understanding their concerns. Emphasize partnership and collaboration over time. Very important. Some hot topics that you will find is fertility. It's not always relevant if the child is too young, but if you're about to go into potential puberty blockers or plus hormones, understanding the different options for puberty, for fertility, preservation, and family building are really important. Some young people and families are not ready to discuss surgeries, and some families are most helped by having really a sort of a timeline, a chart of all of the different interventions, medical interventions that will or might become available to them if it's relevant for their young person. Don't try to guess that, ask, and you'll see immediately if the kid, if the family members are ready. If you see that there's a difference, this is sometimes where I say, okay, great, it sounds like some people are ready to have more information, some people are not. Whoever wants to stay in the room. Obviously, if a child wants more information and the parents is not in agreement, you need to negotiate that with the parent first. And as I said, when caregivers disagree or in conflict, I let the child know that some kind of consensus among decision makers is going to be really important, and they're going to pay attention to that. And I sometimes structure the session or the medical advice for the medical session to be done in maybe in different parts. Have referrals at the handy, and some psychosocial support, some community-based support, some education and advocacy organization can be most helpful. These are some writings on the topic, including all the data that was discussed in today's presentation. Again, I know this was really fast and a lot of information. Thank you so much for listening. I look forward to meeting you live and remotely in this morning. If you want more information, you can find some of the articles discussed on my website. Don't hesitate to email me or to follow me on Instagram for any posting on further training and lectures. Again, thank you so much for your time and attention. It is my pleasure. Thank you so much.
Muchas gracias por la excelente presentación.
Thank you very much to everyone for the presentation. Now I'll have to introduce a colleague of mine, Dr. Daniel Metzger, a pediatric endocrinologist in the BC Children's Hospital in Canada, and also a professor in the Division of Endocrinology, Department of Pediatrics, University of British Columbia. Dr. Metzger and his colleagues have been taking care of trans and diverse gender youth for more than 25 years. He has one of the centers with the highest number of patients in North America. So let's hand the.
Hi, good morning. My name is Dan Metzger, and I'm a pediatric endocrinologist at the Children's Hospital in Vancouver, Canada. I'm delighted to be able to speak with you today, and I'm hoping you're having a good meeting. I've been asked to address the challenges in the management of non-binary youth and young adults. I have no conflicts of interest. I will be speaking about estrogen, testosterone, and puberty blockers, but I do have to recognize that none of these have Health Canada or United States FDA indications for use in trans individuals, and I would imagine that that's true throughout most of the world. I will be discussing some suggested off-label use of other medications, which could have a theoretical benefit or risk to patients without actually recommending their use. And hormones, phenotypic sex, and puberty are generally binary. And so I will be using a lot of binary language when I'm talking about non-binary youth. In this session, I'm hoping to be able to describe for you the current estimated prevalence rates of trans and non-binary people. I would like to explain some of the clinical challenges in the endocrine management of non-binary adolescents and young adults. And I would like to review the current literature on treatment options for non-binary adolescents based on the young person's pubertal status and embodiment goals. Firstly, a bit about demographics. Unfortunately, I only have North American data to share with you, but I understand the situation is similar in Europe, and I would assume also in South America. If we look at US data, the Williams Institute did a large survey amongst United States adults who are greater than 17. They identified that about 0.5% of those folks identify as trans or gender nonconforming. Of these, 38.5% were trans women, 35.9% were trans men, and 25.6% described themselves as gender nonconforming. Of those youth who are in the age group of 13 to 17, about 1.4% identified as either trans or non-gender conforming. The same is also true for those who are in the 18 to 24 category. About 1.3% identify as trans or gender nonconforming. The United States data also shows that of those who are assigned female sex at birth, about 0.6% identify as trans, 0.3% identify as male, and 1.7% identify as neither cis nor trans, indicating that they would identify as non-binary. The numbers are very similar for those who are assigned male at birth. Canada was the first country to provide true census data on transgender and non-binary people. And in Canada, as of a year or so ago, 1 in 300 people aged 15 and older identified as either trans or non-binary. Of these, of those identifying as non-binary, about 1/3 of those were assigned male at birth, and about 2/3 of those were assigned female at birth. This was a total of about 41% of those people who identified as trans or non-binary. And not surprising to anybody who works in gender clinics, that the younger that the patients were, the more likely that they were to identify either as trans or as non-binary, and certainly more of those presented as non-binary. Let's talk about non-binary people a little bit. And I understand that I'm going to be speaking in English today, and that some of the concepts that I think about in terms of non-binary and pronouns will be a little bit different, or perhaps quite a bit different in other countries and other languages that may or may not have more gendered phrases in their language. Non-binary in English is used as an umbrella term to refer to individuals who experience their gender as outside of the gender binary. Non-binary people may identify to varying degrees with binary associated genders. So a person who identifies as non-binary man, a non-binary woman, or they may identify with multiple gender terms, such as non-binary, simply non-binary, or in English, gender fluid. Non-binary also functions as a gender identity in its own right, and the same identities can have different meanings for different people in different cultures, in different languages, and the terms that they use can vary over time and by location. Why is it important to know specifically how those people who are identifying as non-binary, why do we need to know how they might be different than the more binary trans kids that we meet? One of the most important things to know is that the mental health issues in non-binary youth have been shown to be more common than in their binary colleagues. The large trans youth health survey in Canada looked at nearly 1,000 kids in the 14 to 25-year-old age group. And of those, 41% who identified as non-binary, they reported poorer mental health outcomes, higher rates of self-harm compared to those kids who identified as being binary trans individuals. Non-binary individuals' poor mental health outcomes can possibly be explained by the lack of recognition and absence of information or resources or non-binary models. And I think we've all seen this, that it's hard enough for some people to grasp the idea of a binary trans individual, but then to add non-binary identities on top of that is something that's just outside many people's understanding so far. Well, what can we as endocrinologists do? We're very likely in our normal practices to encounter a youth or young adult who may identify as non-binary in our endocrine clinics or in our diabetes clinics. We would like to always review with the family the preferred name and the pronouns and get a sense with them with where they are on their gender journey. Not all binary individuals are necessarily looking for medical or surgical transition, and it's important to know what local resources are available in your communities for non-medical or medical support. And if medical support is needed, then individuals should be first assessed by trans-competent mental health specialists before they are referred to those of us who simply do hormone prescriptions. What kind of evidence do we have? What sort of guidance do we have in helping our decision-making? Well, we have the Endocrine Society guidelines from 2017. They're getting a bit outdated, but they still do contain dosing regimens, particularly more aligned for those who have binary identities. Obviously, the WPATH Standards of Care version 8 has an entire chapter devoted to binary people. We have publications from different studies, but not whole lots out there around non-binary youth and young adults. We certainly have clinical experts in the field of transgender medicine, but also some of our other colleagues in gynecology, adolescent health. Sometimes our surgery colleagues can bring in their perspectives as well. We have local standards of procedures. We have state, provincial, national guidelines that we have to adhere to. And as endocrinologists, we can also apply our knowledge from other conditions that help us decide what kinds of treatments might be available that are not just simply testosterone, estrogen, or blockers. So for instance, when we think about patients with hypogonadism or virilizing conditions, that gives us extra knowledge or insight in how we may be able to formulate treatments for non-binary individuals, as I'll show you as we go along. To go back to the WPATH SO8 criteria, there are 4 recommendations made by WPATH in terms of those people who identify as non-binary. They recommend that healthcare professionals provide non-binary people with individualized assessments and treatments that affirm their experience of gender. They recommend that healthcare professionals consider gender-affirming medical interventions, hormone treatments, or surgeries for those non-binary people who may or may not feel like they need to do a social transition prior to that. They recommend that healthcare professionals consider gender-affirming surgical interventions in the absence of hormonal treatment, unless hormonal treatment is required to achieve the desired surgical result. And finally, they recommend that healthcare professionals provide information to non-binary people about the effects of hormone therapies, surgeries on future fertility, and discuss the options for fertility preservation prior to starting hormonal treatment or undergoing surgery that may alter fertility. As we go along, I think one of the things that you will see is that we do have some ethical situations that arise, not only just treating trans youth in general, but ones that are maybe particularly more associated with those people who identifying as non-binary. So when we have ethical decision-making requirements, the first thing we want to do is to identify the ethical concerns, remembering that we want to keep in mind what is the best of the interest of the patient, to gather relevant information, identify options, consider consequences, and then make, implement, and evaluate a choice. We need to be transparent with our patients. We obviously want to work with patients to achieve their goals around embodiment and how they would like to look and how they would like to present themselves. But we also have to be realistic when we talk about medications that may be off-label, that we may or may not be comfortable with prescribing, and where we actually have an absence of information about a treatment that may be suggested by a patient or a parent. I would like to present a case that we developed just to bring up some of the issues that I'm just talking about in terms of the ethical considerations. This is a 14-year-old youth who was assigned female at birth and who uses they, them pronouns. So this patient was seen in endocrinology after having been assessed by a trans-competent mental health specialist. Since a young age, they knew they were different from their friends. At age 6, they cut their hair short. And from around the age of 10, they knew that they were non-binary. They came out to other family members and to schoolmates between the ages of 11 and 12. And this kid is now 13 years of age. The patient, came out to their parents about a year ago prior to the assessment. And this identity, this non-binary identity, has been consistent for over 12 months. The patient had menarche, which for them was the worst thing in the world. They have been having menses now for about 2 years, and the gender dysphoria that they relate to, particularly around menstruation, is rated as 9 out of 10. This patient states, "I hate being in my body." The gender issues impact the mood a lot. They often are anxious. This patient has had 3 suicide attempts, one with an overdose of medication, ongoing self-harm, and ongoing suicidal ideation. The bone age for this patient is 16. They are on the 75th percentile for body mass index. Their embodiment goals is that they would like puberty blockers to stop periods. They're not interested in gender-affirming hormones in the future, nor necessarily any kind of genital surgery. They would like, down the road, top surgery, hysterectomy, and salpingo-oophorectomy when they are old enough to have this. So which of the following would be the next best step for this individual? You could discuss all of the options of menstrual suppression, including a GnRH analog, combined estrogen progestin medications, oral progestins alone, depot or subdermal progesterones, or intrauterine devices, and then coming to a decision based on the patient's individual or patient or family's individual treatment preference. Another option is that you could encourage oral progesterones, continued combined hormonal contraceptives, or medroxyprogesterone to suppress menses as the patient is postpubertal with no future goals of testosterone treatment. You could recommend not starting treatment yet because they've not experienced gender incongruence long enough. Or option 4, starting with a GnRH analog, as this is the best option for menstrual suppression. Well, probably the best answer would be A, discussing all of the options of menstrual suppression, including blockers or continuous oral contraceptions, the progesterone-only pill, maybe depot medroxyprogesterone, or an IUD, depending on their sexual activity. And obviously, this is a decision that we want to based in the patient's best interest and what serves them the most. If we look at WPATH SOC8 criteria, this is under the adolescent chapter. They recommend that providers consider prescribing menstrual suppression agents for those adolescents experiencing gender incongruence who may not desire testosterone therapy, but who desire but have not yet started testosterone therapy, or in conjunction with testosterone therapy for breakthrough bleeding. So menstrual suppression options include, as we mentioned, combined oral contraceptives, progestin-only pills, or depot or subdermal progestins like depot medroxyprogesterone, or an IUD. So in this patient, the choice was made to start with a puberty blocker, a GnRH analog. This respected the patient's autonomy. It stops the menses better than any other treatment that we have. It improved the patient's gender dysphoria, improved their day-to-day functioning, and it helped lift a bit their depression and anxiety. But there are some risks with long-term GnRH analogs, as we'll see, that we know that they can interfere with bone calcium accrual. We may see some bone loss, drops in bone mineral density scores, and we worry about the ongoing risk of increasing osteoporosis. There are some unknown risks. Do we know, does reducing sex hormones affect neurocognitive development? This is still an area of active research and uncertainty. What about the risk of infertility if the patient is treatment is prolonged for a number of years? We're not, we don't have lots of evidence that that's a viable concern, but it is something that parents will bring up. And what about other long-term risks of untreated hypogonadism, for instance, cardiovascular risks? So this patient, 2.5 years later, has been on now depot Lupron. The patient is 16 years and 9 months, and they still do not desire any sort of gender-affirming hormones in the way of testosterone. This patient gets extremely anxious and panicky when you discuss other menstrual suppression options, as they know that there won't be a guarantee that other medications will completely stop menses. They're not really old enough to have a hysterectomy, at least where we live. We've been following the bone mineral density, and this is what we find. This patient had a relatively normal bone mineral density, but now 2.5 years later, the patient is has quite a low bone mineral density, with the Z-score falling from -0.5 to -2.2, and the actual bone mineral content dropping from 44 grams to 41 grams. So we have overall net bone loss. So at this point, you would strongly recommend discontinuing the GnRH agonist, given the threat to bone health. You review other options of menstrual suppression, but the patient would like to continue the GnRH agonist for a few more years. What would happen if they remained on this agonist as long as they desired? Could we consider other bone protective medications, such as a bisphosphonate? And with further discussion, we strongly encourage the patient to transition to continuous hormonal contraception or to an IUD. A number of ethicists and other clinicians have started looking at the ethics around allowing a patient to be on blockers and have no puberty for an extended period of time. And this and another study really did show that at some point, we can't let patients not go through puberty when it's starting to show some harm in their bone mineral density, for instance. And this was just one study of a number of people in Australia, and most of them were happy for a patient to be on a puberty blocker for a few years, but after that, they found that it was ethically not always feasible to allow the patient to continue. We actually have an extreme example of a patient who went for a long period of time without sex hormones. There was a famous castrato named Gaspara Pacirati, and there has been some study done looking at this man's bones, whose testicles were removed early in life so that he could be a good singer, a good soprano singer for a long period of time. And clearly, just looking at his bones, you can see that there are some problems, and an x-ray of his spine shows that there's quite severe osteopenia. When we think about treating non-binary folks, and also to some degree binary folks who want something a little bit not completely testosterone or estrogen only, there are a number of medications that we can think about that can help us out. And some of these medications come from other endocrine diseases that we look after. So if we think of the progestins, the progesterone family, there are a number of them. Micronized progesterone, we have medroxyprogesterone acetate, which we can take orally or intramuscularly. In Canada and Europe, we have cyproterone. I'm not sure if that's available in Chile. Linestranol is available in Europe. We don't have that here. Norethindrone, we have progestin-containing IUDs, and we have the implants, the progestin-only implants, which were designed for contraception for cisgender girls and women. So in general, these are already in use for pubertal suppression. So prior to having pubertal blockers, and in places where patients can't afford pubertal blockers, we can still use Depo-Provera, so Depo-hydroxyprogesterone, which does a decent job of turning off puberty and getting rid of periods. In those patients who are assigned female at birth, they can be used for menstrual suppression and contraception. That's their primary use. For those assigned male at birth, you can lower androgen levels. You can increase breast growth a bit. There is a thought that you could use progestins to increase libido. Some of progesterones have a bit of an androgenic effect. When there are some thoughts that they could be cardiovascular protective, some progesterones in some situations, and some patients take progestins to help with their mood, although they can also cause negative effects on some mood. Well, what would be some of the theoretical uses of progesterones in non-binary people? In those assigned male at birth, you could consider lowering the testosterone, not completely, but knocking it down, say, to a lower level without having to use the full guns puberty blockers, which would lower the testosterone to undetectable. In those assigned female at birth, you could do the same sort of thing. You could give just enough to suppress menstruation, but not having to use testosterone, as we've seen in our patient that I've just shown you already. And in those folks who are on GnRH agonists already, could we use some progesterones, for instance, norethindrone, which may controversially have a benefit of protecting the bones a little bit by increasing bone mineral density, or at least decreasing the loss of calcium in the bones. There are, of course, side effects with the progestins, depending on which one we're talking about. They are not always perfect at causing menstrual cessation. They're not always perfect at contraception, particularly if you don't take them properly. Different progestins have different effects on bones, and there is still some debate about whether or not they can have a protective effect on the bones. Some of them are more androgenic, which can be useful in some situations and not so useful in other situations. Some have a thrombogenic risk, and cyproterone in particular does have a tenfold increased risk of developing meningioma. Still a very rare cancer, but something that you can't ignore. When we talk about selective estrogen receptor modulators, another group of drugs that people have proposed for non-binary people, there are a number of SERMs out there. Tamoxifen, first generation, raloxifene, second generation, and these others are third generation. And as these drugs have been developed, they have a good estrogen effect on the bone, but little or no estrogen effect on the breast. So these drugs were developed for women with breast cancer who were treatment after to help lower estrogen effects on the breast post-treatment for breast cancer. But one of the things that we do see with these drugs is that the risk of a deep vein thrombosis is higher using these drugs than it is with estrogen alone. So while these drugs can have a positive effect on the bone, no effect on the breast, we do see some effect with coagulation problems. Well, what would be the theoretical use of these SERMs in non-binary people, those assigned male at birth? Well, we could, for instance, allow for some estrogen-like protection on the bone without effects on breast. So one of the things we don't know when we would use a SERM is, can we achieve peak bone mineral density when we are providing an estrogen-like drug that's not affecting the breast, but is affecting the bone in a positive way. And it would possibly also give you some estrogen-like changes in the skin and fat, which a non-binary person might want. There are no endometrial concerns, as far as we know from the information that we have. We have no understanding of what these drugs do in terms of CNS development. We're talking about people who still have a developing brain. And we are not 100% clear on the effect of lipids, thrombotic events, and cardiovascular risk in young adults or older teens. The side effects of the SERMs we know from those cisgender women who are breast cancer survivors. Hair loss is common, nausea and mood changes. They will lead to menopausal symptoms as they lower the estrogen. We know that the risk of DVT, as I've shown you, goes up 54%. Pulmonary embolism increases 91%. The risk of type 2 diabetes goes up 31%. And there is a hypertriglyceridemia with hepatic steatosis, which can result from the use of SERMs. Some SERMs do also increase LH and FSH, and thus also increase testosterone, and that sometimes kind of negates what you're giving the SERMs for in the first place. Another group of drugs we can think about are the 5-alpha reductase inhibitors. Finasteride and dutasteride are the drugs that are available in North America. And for those folks who are assigned male at birth who are taking estrogen, but they want to preserve erectile function, you could allow for some testosterone to remain in the bloodstream, but because hair and skin are sites of 5-alpha reductase activity, you could hopefully lessen the effect on the skin and the hair. So for those patients who want erection still, but want to not have not increased body hair, some people have proposed the use of 5-alpha reductase inhibitors. And for those people who are assigned female at birth who are taking testosterone, and again, if they don't want a lot of body hair, but they do want to have voice changes, this might be one way of trying to achieve that. And then finally, as is used in cisgender men, you can use 5-alpha reductase inhibitors for androgen-dependent hair loss. And I have a number of trans patients who are starting to go bald with their testosterone because that's what happens in their families. And we will sometimes use 5-alpha reductase inhibitors for those people. But there are side effects of the 5-alpha reductase inhibitors as well. Again, mostly known from cisgender men who are taking them for prostatic hyperplasia or for balding. They can increase testosterone levels and then as a result increase the estrogen levels, which might actually be counterproductive. They could promote the growth of high-grade prostate cancer in some people, not generally a consideration that we have to think about in the pediatric or adolescent age group. They can be associated with rates of depression and low mood. Again, that's mostly from older cisgender men who've got cancer. And they are known, though, to lower libido and increase sexual dysfunction in cisgender men who want to preserve, who would like to be able to preserve their sexual function. Another group that's been proposed are the aromatase inhibitors. And again, in North America, we have anastrozole and letrozole. As you know, these drugs block the conversion of testosterone to estradiol and of androstenedione to estrone. When you give these medications, they can increase testosterone levels in cisgender men. So how might we use these medications in those folks who identify as non-binary? Well, just like we do in cisgender boys, we sometimes will offer aromatase inhibitors, and you could theoretically increase the final height in those folks who are assigned female at birth, who are obviously going to be on average shorter than cisgender boys. You could propose that you are decreasing the production of endogenous estrogens in those people who are assigned female at birth who still have some estrogen around. You could minimize the feminizing effects of testosterone in obese individuals. Testosterone, as we know, can be converted into estrogen peripherally, and sometimes that leads to some gynecomastia in things that may not be what the patient desires. Lastly, you could consider preventing breast growth in those assigned males who are taking spironolactone. Most binary kids who take spironolactone get a little bit of breast growth. They're happy about that, but that might not be the case for a non-binary individual. The side effects of aromatase inhibitors can be hot flashes and decreased bone mineral accretion, which would not be something we would be particularly happy about. The last group I'd like to talk about are those non-steroidal androgen blockers, such as flutamide and bicalutamide. They block the androgen receptor. They can block androgen action, but they counterproductively will increase estrogen and estradiol. These can be used in place of or in addition to spironolactone or cyproterone. And in assigned males, you could theoretically use these drugs to decrease the masculinization, but still preserve bone mineral density. You could combine them with cyproterone to lessen the testosterone level and effect without having to use full doses of either. Unfortunately, these drugs do have a possible side effect of hepatotoxicity, which can be fulminant and rarely lethal. There are other number of non-hormonal therapies that we can offer to non-binary folks, just as we use in cisgender people and binary trans folks. Many patients who may or may not want hormones, but they may want top surgery, like the patient I presented. Hysterectomy and gonadectomy can be options for non-binary folks as well. A more complete surgery that's not particularly common, at least around where I practice, is a surgery called gender nullification, where the genitals are neither virilized nor feminized, that they are more put into a gender null configuration. And then, of course, other cosmetic surgeries around facial feminization surgeries, Adam's apple surgeries, and voice surgeries, things like that, that are also not commonly, but that also can be done for binary folks. Sometimes patients need hair removal, and we have eflornithine as a topical option, and more definitive options, of course, laser and electrolysis. And then for those patients who want a bit more hair and don't want to take an androgen, the minoxidil can sometimes be used. And apparently you can get a small bit of beard growth even from topical minoxidil without having to use androgens. Well, I do want to point out that these treatments I've been talking about, they're all proposed theories, proposed drugs. None of them are licensed for this. And there is zero information, really no studies on any of these drugs. And to be perfectly honest, we don't use them. And most of the pediatric and most of the academic adult endocrinologists that I know do not use these medications as I've just talked about, but certainly in more private situations, these things happen. I think we have to think about treating kids with these medications even differently than in an adult. Because these kids have not reached bone mineral peak bone mass, and they still have adolescent brains and things like that. So what would our patients like to know? What would we like to know? Well, we'd like to know if we can suppress menses or puberty with analogs for many years or even indefinitely. Is there a safe way to do that? It doesn't seem like there is. What would be the consequences of long-term use of GnRH analogs? We know the effects on bones. We worry about other effects as well. Is there a minimum low dose of hormones that we can prescribe that might be bone protective, but that also prevents undesired secondary sex characteristics? And even so, is this enough to allow peak bone mass, which as pediatric endocrinologists, we feel is quite important? So I think our take-home messages, recent North American data show that around 0.8 to 1.5% of youth aged 15 to 24 identify as trans or gender non-conforming. Of these, roughly a third identify as non-binary, and of those identifying as non-binary, about 1/3 are assigned male at birth, 2/3 assigned female at birth. Non-binary youth represent a new paradigm of care for pediatric endocrinologists who want to help their patients achieve their often non-binary embodiment goals with relatively binary acting hormones. Ethical issues arise when patients and providers have to balance the use of treatment options that are unsafe or off-label with the long-term mental health safety and well-being of the patient. Novel treatment regimens for non-binary people, with as yet no studies to justify their routine use, are being proposed to help modify or enhance our current hormone replacement regimens for binary trans people, and extreme caution must be taken in the use of these medications, especially in non-binary youth who have not achieved peak bone mass. We still have lots to learn about how to best help non-binary people. I would like to thank you for your attention, and I look forward to meeting you for the question and answer period. Thanks so much for your attention.
Muchas gracias por las excelentes presentaciones.
Thank you very much for the excellent presentations. It is a challenge, the hormone therapy in non-binary people. There is still a lot to learn. Now, we will have the Q&A session. I don't know whether the professors are connected. Thank you very much, everyone, for your presentation. Thank you for sharing your experience and knowledge with us. If there are questions from the audience here at the auditorium. There is a question? Yes. I would like to ask Dr. Sierra, based on the very interesting topic he mentioned, I would like to ask Dr. Sierra to tell us about his opinion on the care, between the need of depathologizing neurodiversity and sex-gender diversity, and the difficulties regarding access to health care, because depathologizing implies, for example, for those that use different systems, it implies the needs of not using the diagnosis, but they need diagnosis to have access to health care, because in order to have access to health care, you need certificates, documents that we have to issue. We're not happy doing that. And they mean pathologizing. So I would like to know the opinion of Dr. Sierra in that regard. We are not listening, Dr. Sierra. Unfortunately, we're not listening, Dr. Sierra.
No se escucha, sí.
Unfortunately, we can't hear. There are technical problems here.
Tienen que regular el audio.
They have to check the audio.
Hay una pregunta a Malpas también.
Tenemos que conversamos entre nosotros.
Shall we talk amongst ourselves?
Parece que Malpas escucha.
Jean, can you hear us?
¿Usted nos escucha?
Interpretation, can you hear the
Para que
interpretation?
nos pueda hablar.
Can you say whether you're listening to the interpretation? I'm the interpreter. Are you listening to me? Please raise your hand or something. Oh, great. You're listening to me then. Great. Great. Thank you.
No.
Jan tampoco escucha. ¿Y el doctor Metzger?
Doctor Metzger, ¿usted nos escucha?
Dr. Metzger, can you hear me? I'm the interpreter. Are you listening to me? Yes? Great.
Sí. Ninguno de los tres nosotros no los escuchamos.
Unfortunately, we can't hear you. I'm so sorry.
¿Y si nos escriben?
Había una mano levantada, sí, para poder, mientras recoger preguntas.
Well, good morning. I'm Dr. Caduceo. Thank you very much for the presentations. I am a pediatrician. I'm in charge of child endocrinology in Punta Arenas, southernmost tip of Chile. And in Punta Arenas, we have a program that is in charge by Dr. De Petri and Rodrigo Alvarado. They support transgender patients. The thing is that as a team in general, we request a certificate, mental health certificate, before starting treatment. But I have the feeling in one of the presentations they said that they supported the idea of not requesting those certificates. So at least as a team, we have more peace of mind with that, because we are a team. It's not only the endocrinologist, the one that will treat the patient, but it's a whole team of mental health, child endocrinology, adult endocrinology, social worker. So as a team, I think we have more peace of mind if we know that there's been an assessment, well, an assessment of the child, and that the family has been able to understand, because there are some medications And I think it is a kind of safeguard for us as a team to have a report given by the mental health team that the family and the patient understand what we're going to do and they are ready to start the process.
¿Cómo nos escuchan?
Can you hear us?
Sí.
Y Rodrigo Sierra, pregúntale a Rodrigo si nos escucha.
Así nos escuchan.
¿Rodrigo nos escucha?
Ro, ¿podrías hablarnos?
Rodrigo?
A ver si intenta hablar Rodrigo. No.
No.
Vamos a escuchar a Rodrigo.
Quizás podríamos empezar a...
Maybe we could discuss amongst ourselves for the time being. We can talk about the certificate, opinions about giving a certificate and that aspect. Well, the experience of our team in Catholic University, our backing on mental health intends to help pediatric endocrinologists to be clear that the adolescent, the child, can be aware of that decision they're going to make. Obviously, we move far away from the request of the family of certifying identities because this is very complex. And be aware that the child that is undergoing puberty understands the consequences, that person can make an informed and free decision. I think this is the emphasis on this. What we have to move away, and it is then when there are those tensions amongst the health providers, because sometimes they request a diagnosis of gender dysphoria or a specific sex-gender identity. Sometimes the healthcare systems require a diagnosis. Rodrigo?
Sí, no sé si se está escuchando ahora. ¿Sí?
Can you hear me now? Yes. Rodrigo, we can hear you. Go ahead.
Perfecto.
All right.
Entendí que ambas
I understood that these questions were related, right? Yes.
Perfecto.
Perfect.
Okay, sobre los diagnósticos,
regarding diagnosis, there are several topics that have to do with the with clinical situations where our behavior is not necessarily subject to the need of making a diagnosis. There is what is called working diagnosis. Or how can I put it? Diagnosis which cannot be considered as pathologizing or the presence of a pathology of a condition. Very typical examples are care received by pregnant women. There is a whole system of healthcare provision, follow-up. All of that is covered by the healthcare system, but this is not considered as a disease. It is understood that pregnancy is a normal situation in human life. So the challenge is to start start rethinking about those philosophical bases regarding the way in which we provide care to our patients. In this case, it is much more difficult because there is a historical tradition that goes in a different path. And this is going to be slow over generations trying to change that. About neurodivergence, non-conforming gender, it is interesting to see what happens with the different theories of disability in this regard. And this involves philosophical fundamentals. The point is that human needs come from dignity, and they do not go through a diagnosis. In that sense, the idea is to think about the needs of people, cater those needs, rather than using the traditional medical approach of using a diagnosis, because in practice, many people have the same diagnosis, but their needs will be different. That's valid throughout medical practice. We have to try and see how to do that. Of course, in practice, there are other factors which are not medical that will affect those dynamics. For example, the fact that the diagnosis of gender in Congress in ICD-10 meant that there were medical insurances that they started to say people, if there was no medical diagnosis, if that wasn't ADCs, that fell under the sphere of aesthetic treatments. So medical provisions were not going to be covered. And so that is a very clear example that there are factors that are not necessarily medical, corresponding to the medical practice. About issuing a certificate. Those who work in affirmative teams is using certificate for the well-being of the patient, for the sake of the patient. When diagnoses are necessary, diagnoses are made, the documents are issued to make sure that the insurance covers the treatment, to make sure that the patient has access to treatment. But we talk to the person at the time about the purpose of which, why that language is being used. A document that says gender dysphoria, or a document that says autistic spectrum disorder, rather than saying autism only. And finally, I'm going to refer to this dynamics on certain tendency of judicialization of medicine, that we have to safeguard ourselves from patients. But the thing is that there should be trust between the physician and the patient. I'm sorry I'm speaking so much, but I think this is very important. There is another role. Well, we have to see what the role of the mental health team and what is the role of psychiatry. Assessing the consent capacity is something that everyone in a medical area should do. When we are in different endocrinological treatments, other pediatric treatments, we are not always calling a psychiatrist to ask whether the patient can consent or not. We have to ask ourselves why, in this situation, this is different. This is critical because
No, como decía Marcelo, lo escuché,
As Marcela said,
no podemos certificar la
we
identidad de
can't
las personas.
certify the identity of the
Nadie
person.
tiene
Nobody
como esta fórmula mágica, esta
has a
esfera
magic
de
formula,
cristal para poder
this crystal ball,
decir a ciencia cierta qué es lo que
to
va a pasar en
say
el
for
futuro
sure
con esta
what will
persona.
happen in the future
Lo que
with the person.
podemos ayudar en decir,
We can help
efectivamente, acá, no
by
sé, hay otros
saying that
diagnósticos de salud
there are
mental, por
other
ejemplo, esta
mental health
persona
diagnoses. For instance,
está en tratamiento por
this
depresión,
person
está en
is under
tratamiento por
treatment
estrés
for
postraumático,
depression,
y lo que puedo
PTSD,
evaluar yo
and
es
what I
en qué
can
medida
assess
esos
is to what
diagnósticos
extent
o
those
sus manifestaciones
diagnoses or
clínicas
their clinical
podrían estar afectando
manifestations
o no
could be.
la capacidad de consentir. Pero no puedo extender un certificado de que alguien es trans, por ejemplo. Siempre hay que estar pensando en el otro sentido. ¿Extendería yo un certificado para decir que alguien es cisgénero? ¿Qué implicancias tendría eso?
Muchas gracias, Rodrigo, por tu respuesta, bien iluminadora. Tenemos ahora una pregunta para Jan Malpas, que viene de las personas que está conectada por Zoom. Y quiere hacer un comentario, parece primero, Jan. Jan, te escuchamos ahora.
Can you hear me?
Yes.
Okay, great. Looks like we can hear each other on the Zoom and in the room. Thank you so much for having us. It's a pleasure to be here. And I just wanted to jump in on the question about evaluation and assessment. And I agree with most of the points that Dr. Rodrigo Sierra made. I think what we're trying to balance here is the balance between quality of care and gatekeeping. So we were trying to increase access and decrease gatekeeping in any of our fields, whether they're mental health, social care, or medicine, but also have a sense of the quality of care and the readiness of the young people and their family. You know, the child and adolescent and endocrine chapters of the World Professional Association of Transgender Health, latest version, the 8th version, do mention assessment and evaluation and holistic assessment and evaluation of young patients and their families to have access to care. I think the question is how the assessment is done and how gatekeeping it is, like how it decreases access. I do think it is really important to have a sense of the mental health of the young person, a sense of potential conflicts around ability to sustain care and attend care and continue to have access to care, mental health and medical, and potential barriers in the family or in the social setting. But I think it is on a case-by-case basis, and often a location and a setup. It depends on the clinic, on the hospital, on the family, on the young person. But that in an ideal way, we don't take away completely the psychosocial assessment. We adapt it to the setup, and we adapt it to the case, so that we don't use it in a way that prevents access to care, but we use it in a way that we can address potential secondary or co-occurring mental health concerns or relational social concerns and safety concerns, for instance, that the young person might have and might prevent access to care. I'm getting a message saying that, you're not getting the translation on the Zoom. Got it. And Dr. Metzger, I did turn on my captions.
Metzger.
So,
bueno,
just a tip here on Zoom.
Bueno, eso es lo que quería agregar, que la evaluación tiene que establecerse para cada clínica según el profesional también.
Muchas gracias, Jean.
Thank you,
Hay otra
John.
pregunta para
There is
Jan de
another
acá de
question
la
for
doctora
Jan
Paola Oñate.
by
Y
Dr.
la
Paola
pregunta es, en
Oñate.
su
The
experiencia,
question
¿qué
is, in
factores o
your experience, what
elementos
factors or
identifica como
elements
asociados
you
a la
think are
desistencia?
associated
¿Y a qué edad se ve
to
más
giving up?
frecuente que ocurra?
And at what age it is more frequent that this
To listen
happens?
to the translation.
Can you hear me? Can you hear me? 1, 2, 3, testing. Can you hear me? Now can you hear me? It was about giving up, when the patient gives up. It was about that, the question. Why is that? How often? Can you hear me?
No, I can't hear you. Can you say a little bit more about the question?
Desgraciadamente no nos está llegando el audio en la cabina de interpretación de Jan. No estamos recibiendo el audio. Ella pregunta sobre su experiencia. ¿Qué factores y elementos identifica que se asocian con desistir y en qué edad es esto más frecuente? Desgraciadamente, we are receiving sound from Dr. No estamos recibiendo el sonido en la cabina del doctor Sierra, en la cabina de interpretación.
Okay, I'm going to move back to the audio here. Can you now hear me in the room?
Ahora lo podemos escuchar en la sala. We can hear you. I mean, I can hear you, the interpretation. In the interpretation booth, we can hear you. Desgraciadamente, el audio no nos está llegando a la cabina de interpretación. No estamos recibiendo el audio los intérpretes.
and affirmed enough to be able to say, with the advent of puberty, I might feel comfortable in the body that and the assigned sex that I have, and change. So we don't, I think that the question was also about what are some factors in persistence and desistance. I don't think we have actually a lot of information from the research about which kids tend to be more likely to persist or likely to change their mind or have a more fluid gender identity over time. I'm curious if Dr. Metzger and Rodrigo Serra have any thoughts or information about that. I think we know now that we have some kind of information on the timeline. I don't know that we have information about the kids themselves or factors of persistence. We have said in the past, the say persistent, consistent, and insistent has been sort of a popular way of trying to articulate the fact that the kids who are very likely to continue to identify as trans in adolescence and adulthood are really adamant, it's a really vital, urgent, and core aspect of their identity. And the distress that they experience in not being affirmed is extremely serious and sometimes life-threatening. So I think that we know a lot about how these kids experience the lack of affirming care. But I'm curious to see if there's any other thoughts on those factors.
I would say, I think sometimes people get all upset. I'll give two instances. A patient assigned whatever at birth decides to start puberty blockers because they're not certain really where their journey is taking them. And they take blockers for a year or so. They see their mental health provider, they explore their gender, and they decide, you know what, actually, I like the body I was born in. And they come off the blockers. That's a good thing. That's a person who figured out where their journey is taking them. That's not a mistake. That wasn't detransitioning. That wasn't, a thing that we all have to, add to the statistics of what bad is happening. I think another instance that we see is as a kid, say, assigned female at birth, they come wanting testosterone. Everybody thinks this is a good idea. The kid takes testosterone for a year or so. The voice changes. They're starting just a little bit of beard, and they're like, you know what? This is the body I want. I thought I wanted this, but actually this is the body I want. I'm really happy. I'm just going to stop my testosterone. I'm okay with having periods again. And again, that's not a mistake. That's not detransitioning. That's a person who's found themselves and whose gender journey has taken them to the right place. So I think we have to be careful what we call detransitioning, retransitioning. I think everybody's got their own way of doing things, and that's good that we're helping them get to the right place. If you look at adults who detransition, far and away the biggest factor is lack of family support, community support, financial support, and things that are beyond their control. These are people who detransition because they have no other choice. They've got no money to pay for their drugs, their family is rejecting them, their community, their social or religious community is rejecting them, and it's just too hard for those people, or they have other obstacles in the way, poverty, addictions, things like that, that just prevent them from transitioning. So the vast majority of adults who detransition do it for reasons that really, if they have their choice, they wouldn't do it. Regret is very uncommon in pediatrics for sure, and less so, I think, and not that common in adults as well.
We can no longer hear the room.
Of the test with the bone, with the evaluation of the bone density, with the use with the blockers, and if it's useful in the adults. as anti-androgenic.
Español. Uno, dos, tres.
I think I heard a question about blockers and bone mineral density.
Yes.
The question around whether you should do bone mineral densities is, I think, not a settled thing. I think our evidence is starting to show that there are some untoward effects of bone mineral density in patients on blockers without other hormones. There are still studies going on that I think will provide us even better information, but I initially did not want to do bone mineral densities on kids because I wasn't doing a study, and I didn't think there was a rationale for radiating kids with just for my own curiosity. But as time has gone on, I do think that it's a situation that we probably should pay more attention to, particularly in those kids who are assigned male at birth. Trans girls and trans women, for some reason, have lower bone mineral densities even before they start their hormone treatments and tend to have poorer bone mineral density as time goes on. So I'm taken now to doing at least a bone mineral density at baseline on the girls, trans girls. And I await like really a better idea of what we should be doing before I start treating kids. I think it's always good to have a baseline because if there is questions or problems down the road, then I think at least we know where we were starting from. If for the trans boys, is a less of an issue because their bone mineral densities do tend to recover after some testosterone. For the non-binary kids, I think nobody really knows the right answer. But I think, and the other question is nobody really knows once you're on hormones which bones you should be comparing a child to, their natal sex or their affirmed gender. Neither is perfect. And some people do both. Some people go mostly with their assigned sex. That issue is also not really settled. But it is good that there are places that are doing like proper longitudinal studies looking at this to guide us. The Dutch folks, the people in Ottawa, and a couple of centers in the States, and I'm sure elsewhere, people are doing like proper, good longitudinal studies that hopefully will guide us in the future.
Presentadores que nos acompañaron esta mañana, quisiera señalar que
you.